All right, morning, guys. Sorry about all that. I think we finally got it to work. So I'll be presenting a brief overview. I know it's the beginning of the year, and the topic I was assigned was on neurogenic claudication and lateral recess stenosis. Once again, for those of you who I have not met, I'm Ryan. I'm one of the new spine fellows. So starting from the very beginning, what exactly, kind of from a broad overview, today I'll be talking about lumbar spinal stenosis. And as many of you know, um, what lumbar spinal stenosis is, from a broad overview, is a reduction in the actual volume of the central spinal canal, which doesn't just include central spinal canal, but also includes the lateral recess as well as the neuroforamina. And because of with any reduction, it impinges on the nerve roots that are in the central canal or the nerve roots that are exiting the thecal sac into the exiting nerve roots. And as you can see from a radiologic perspective, patients can have the same scan but have many different variable presentations. Some of our patients are completely asymptomatic from lumbar spinal stenosis. Some of them have low back pain. Some of them have a radicular lower extremity, bilateral leg pain, unilateral leg pain. Some of them present with neurogenic claudication. And most commonly, you see sort of a combination picture of a bunch of different presentations from any sort of lumbar spinal stenosis. So today I'll go over the epidemiology, the anatomy, the clinical presentation, indications, and then treatment options, both surgical and non-surgical options. I like this diagram here on the right-hand side, showing different places of lumbar spinal stenosis, different locations. You can see, can you guys see my mouse?
No.
Okay. Well, the right, looking at where if there is impingement of the central canal, the next, if you move from right to left, the next box is the lateral recess, where we refer to stenosis in the lateral recess zone. Then there's a foraminal zone, and then finally there's the extraforaminal zone. For the purposes of today's talk, we'll focus on the foraminal zone proximal. So first of all, prevalence. As anybody who's gone to any spinal clinic knows, lumbar spinal stenosis is the most common reason for patients older than the age of 65 years old, our Medicare population. Up to 9% of elderly patients suffer from symptomatic lumbar stenosis, and more than 500,000 surgeries a day or a year are performed for lumbar stenosis. The average age is 64. 84% are Caucasian in America, and men suffer this or undergo surgery more than women. Low back pain is the most common cause for lost work hours in the United States, and lumbar spinal stenosis is one of the main reasons for that, and it affects approximately 1.4 billion lost work hours each year, and many different risk factors for this. Etiology, it usually, the most common hypothesis of why this happens is disc degeneration with age leads to anterior column collapse, which then leads to abnormal force transfer to the posterior column, ligamentum buckling, causing facet hypertrophy, and then osteophytes, and plus or minus synovial cysts, which impinge on the thecal sac or the exiting nerve roots. Other causes which aren't on the scope of this talk are degenerative spondylolisthesis, achondroplasia, congenital lumbar spinal stenosis, and then synovial facet cysts are also a common cause of lumbar spinal stenosis. Another diagram looking at the anatomy. Once again, that picture on the right shows the different zones, but as you can see here on an axial cross section, we can see where central stenosis would occur versus where lateral recess stenosis and foraminal stenosis would occur as the nerve root exits from the thecal sac and joins the lumbar plexus. How do we work up these patients? Every good patient counter starts with a good history. So want to talk about some of those symptoms look for some of those symptoms that we discussed previously. If they're having low back pain, if they're having leg pain, if they're having neurogenic claudication. A physical exam, we're looking for weakness or numbness, decrease in sensation. Sometimes you'll see blunted deep tendon reflexes, especially in the bilateral patellas. We can also look for, depending on the etiology of lumbar spinal stenosis, if it's a disc, we look at things like positive straight leg raise. X-rays are a good place to start. Always look to see what the upright alignment is. A lot of the, and I'll get to this later, a lot of these symptoms can be exacerbated by flexion, by extension. So looking at flexion and extension X-rays is another good way to start and to rule out other conditions like unstable spondylolisthesis. And sometimes can consider a CAT scan depending on the pathology. MRI is the workhorse of our workup, and we can see the best compression of the nerve roots both in the thecal sac and the exiting using an MRI. And injections can be both diagnostic and therapeutic. We can do transforaminal to see if that is where the cause of the nerve root impingement is, and then we can also do epidurals as more of a shotgun approach to see if that is effective in treating the pain, especially if it's one of the first times that they're experiencing this pain. So starting with central stenosis, the anatomy, as all the spine fellows are well aware of, starting from the front is the vertebral body, the ligamentum flavum posteriorly, and then the facet joints posterior laterally. Any of these can cause, any of these that are increased in size can cause central canal stenosis. And sometimes it's a combination. Sometimes it's a disc bulge plus ligamentum flavum hypertrophy and facet overgrowth. And as I talked about in that degenerative spine cascade, like most times it's a combination of all of those. Most commonly, 90% of cases present at L4-5. 5 to 10% are at L3-4 or L5 to S1, based on the forces used in the degeneration of the disc at that level. There is a high correlation with spondylolisthesis and degenerative scoliosis as well. So how does neurogenic claudication present? The etiology for it, and some people call it pseudoclaudication as opposed to the traditional vascular claudication, is usually because sometimes it can cause, when you get stenosis or impingement of the thecal sac, you're also impinging the epidural veins and the arteries that supply the nerves. And because of this, there's usually a mismatch between the blood supply and what is the oxygen demand required from the nerves. So when when the classic symptoms of neurogenic claudication, you're getting low back pain, bilateral buttock pain, bilateral posterior thigh pain. And a lot of that is due to that mismatch. The blood supply is no longer able to keep up with the decreased perfusion that happens from the actual mechanical compression of the thecal sac and the nerve roots. This is why neurogenic claudicatory symptoms are exacerbated when the patient is standing, walking, and lumbar extension makes it worse because when the patient extends their lumbar spine, the ligamentum flavum buckles up and pushes more onto the thecal sac, which makes that O2 demand mismatch even worse. Which is why since medical school, we're classically taught that neurogenic claudication gets better with lumbar flexion. So sitting, leaning forward on their shopping cart, as that diagram depicts. Most times, patients with claudication have a normal neurologic exam. And the big differential is a lot of time is if there's a concern for vascular claudication. So you have to make sure that you do a comprehensive physical, including checking their distal pulses, their DPs, and their PTs. And if there's any concern, order a vascular study. And a neurogenic claudication typically refers to a central canal stenosis, but depending on if there's also impingement of the lateral recess or foramen, they can cause a radiculopathy as well. There are multiple classification tables that look at on MRI and imaging about how severe the spinal stenosis is. But the most important thing that I have taken away or want you guys to take away is that none of them have been shown to predict treatment or outcomes. They briefly have to do with how much compression there is and what the decreased percentages of the canal. The Lurie et al. Is probably easiest to use and uses basically whether they're 1/3 decrease in canal 1/3 or 2/3 decrease in canal, or a greater than 66% of a decrease in canal. Next up, I'll be talking about lateral recess stenosis. Like that first diagram depicted, the lateral recess is between the neuroforamen and the central canal. And this is kind of that in-between zone. And usually these patients have developed lateral recess stenosis, usually can be from a slip disc, spondylolisthesis, but more commonly it's usually from a facet joint arthropathy, which sometimes can be part of the same disease process. So usually it's from the superior articular process that hypertrophies, but osteophytes, facet cysts, and herniated disc can also always cause lateral recess stenosis. The L5-S1 nerve roots are the most commonly impinged. More than 90% of lateral recess stenosis cases are based on those nerve roots. And depending on the etiology, can be either unilateral or bilateral. Lateral recess stenosis also is diagnosed on MRI. And there's a couple different criteria. One paper from 2011, Stewart et al., had measured 3 different criteria based on lateral recess stenosis. And 3 different criteria they used are: 1, lateral recess height, which is the narrowest distance between the superior articular process and the posterior border of the vertebrae. And they deemed that anything less than 2 millimeters could be diagnosed as lateral recess stenosis. A depth of less than 3 millimeters, so at the cephalad border of the pedicle, if that distance was less than 3 millimeters between the SAP and the posterior vertebral body, that would meet criteria. And then finally, we look at the angle between the lines, as you can see in figure C. If that angle was less than 30 degrees, that would be another criteria for based on the study of meeting lateral recess stenosis. But once again, the imaging findings really didn't correlate with patients' symptoms, but rather was just a tip off of whether the patient may have lateral recess stenosis. And you still need a good physical exam and history to confirm that. Like I mentioned earlier, with extension and that buckling, classically that's shown to have can cause like neurogenic claudication. But in terms of symptom induction by flexion and extension, you can see it was both flexion and extension. In some patients, and flexion or extension could cause a lateral recess syndrome. Treatment for any sort of lumbar spinal stenosis, whether it is neurogenic claudication or lateral recess stenosis or central canal stenosis, always starts with non-operative management in the absence of a frank neurologic deficit. PT, NSAIDs, activity modification are all things you want to prescribe patients when they first come and see you in clinic, especially if they are presenting for the first time. Epidural steroid injections, as I mentioned before, they can be treatment or diagnostic. And in a lot of cases, this can be a bridge for the patient and make them feel better and let the body do the healing. And maybe sometimes after you give an epidural steroid injection, their pain never comes back. From a long-term cohort studies, 30% of patients at 10 years improve with non-operative management, 30% pain stays the same, and then 30% clinically worsen. Indications to do surgery is if they have exhausted 8 to 12 weeks of non-operative management, if they are limited, have a neurological deficit, or they're getting worsening deficit, in combination with moderate to severe lumbar spinal stenosis. And then a different topic, which we'll talk about soon, is mobile spinal listhesis. And a lot of times the treatment for that is fusion to stabilize an unstable spinal listhesis. This picture depicts 3 of the most common types of treatment for central and lateral recess stenosis and from a surgical approach. The laminotomy, the laminectomy, and the MIS tubular are probably the 3 most common, although I'll talk about endoscopic cases a little bit later on. Laminotomy and the MIS are very similar, but the main advantage of performing a laminotomy versus a laminectomy is that you are able to maintain that posterior tension band. You will do a midline exposure, expose the bilateral lamina and the medial facets bilaterally, but you'll take care and caution not to take any of that posterior tension band, or the PLC. And when you're doing this bilateral laminotomy, you want to preserve more of the facet superiorly, where it turns into the pars. And the benefits of doing things like this are you have a lower chance of a dural tear, and as well as reduced postoperative pain and length of stay. And the higher lumbar levels from L1 to 3, because the pars and facet are more narrow, sometimes to get the full decompression of the central and lateral recess, you might need a full facetectomy, which could destabilize the patient and require a fusion later down the road. In the middle column refers to a traditional laminectomy, on which all the midline elements, as well as the medial facet and laminectomy, are removed bilaterally. The caution and the cautionary tale you have to take away from this is that with multiple levels, and even one level, you have a higher risk of developing a post-laminectomy instability. Hospital stays are longer, they have a higher postoperative pain risk, and there's a higher risk of dural tear. And lastly, the approach I was most familiar with during residency is a MAIS, or tubular approach to it, which is very similar to the laminotomy approach, but usually involves a unilateral approach for bilateral decompression. And the main advantage of this approach versus laminotomy is that there really isn't much in the way of muscle splitting. And actually, Dr. Miller and I published a paper a few years ago looking at kind of the long-term durability, and MIS degenerative approach MIS decompression can lead to good long-term outcomes at greater than 2 years, with in our study showing that less than 10% of patients required some sort of fusion after a 2 to 4 level laminectomy. Skip this slide in purpose of time. This is a picture looking at a patient that I was taken from last year's fellow. Taking a case of Dr. Bruffy is looking at a full lumbar decompression with both lateral recess and central canal stenosis. And as you can see, there is a full decompression all the way to the medial pedicle wall. So what are some pearls and tips, especially for the fellows, is you want to make sure that you are fully decompressed all of the pathology contributing to lateral recess stenosis. So as I've mentioned today, it can be a herniated disc, so it might need to be a discectomy if that's causing compression on the thecal sac or nerve roots. If it's a superior articular process, make sure that you've drilled it out or care send it out. If it's a facet cyst, you need to make sure that you come around it and fully visualize it for teasing it off of the thecal sac. Important to make sure that you decompress all the way to the medial pedicle wall. And as I mentioned on that last slide, since in the upper lumbar spine is more narrow between the facets, you have a higher chance of making them unstable if you're not cognizant of that. And as long as you save more than 50% of the facet, it should remain stable. There's other treatments for neurogenic, for lumbar spinal stenosis. There's what classically is between a decompression and a fusion is an interspinous spacer, or something like a coflex, which the goal of that is, in combination with decompression, is to block any sort of extension or the buckling of the ligamentum flavum. But that has a pretty high, between 30 and 40% revision rate. And so sometimes, when I've seen it done, it's been done in combination with direct decompression. And then there's always the treatment option of decompression and fusion. But this is usually reserved more for mobile spondylolisthesis. I wouldn't be a lumbar spinal stenosis talk without the SPORT trial. But a SPORT trial, which we actually talked about at Journal Club, so I won't belabor it, talked about the treatment of lumbar spinal stenosis without spondylolisthesis. And even despite having a high crossover rate, we were seen to have a benefit of surgery up to 8 years compared to the non-operative management. Skip this study in the purpose of time. Finally, I want to talk about foraminal stenosis, which is the last category. I'm not talking about extraforaminal today, but this is just lateral to the lateral recess, and this is starting with the borders of the pedicle on the medial side and then going out laterally. Once again, this can be caused by disc degeneration, osteophytes, as well as spondylolisthesis or scoliosis. There can be static or dynamic. Once again, if you're extending, it causes a decrease in the foraminal area. And most commonly, you can see this presenting as a radiculopathy with nerve root compression. And if the DRG, which is located in the zone, is compressed, it can cause debilitating pain. This can be diagnosed on X-ray, CT scan, or MRI. MRI, you can see on T1, you will see the loss of perineural fat. On X-ray, they have, if the foramen is less than 15 millimeters or the posterior disc height is less than 4 millimeters, that can be a tip-off that patient might be suffering from radiculopathy from foraminal stenosis. Treatment for indirect decompression can be done indirectly or directly. Indirectly, if you're going to fuse, oftentimes anteriorly at the lower levels, L4 to S1 can be done with ALIF. Above L4-5 can be done with a lateral or OLIF, depending on what technique you feel more comfortable with, followed by a fusion, versus a direct decompression can be done with a direct foraminotomy, a fascicectomy, a lateral foraminotomy from a Wiltse approach, and then there's an MIS tubular approach as well as a endoscopic approach to decompress the foramen. We're running out of time, but ALIF can indirectly increase the foraminal height through jacking up of the disc space, increasing the foraminal area, the foraminal width, as well as the 43% increase of the central canal area. T-lifts as well are an option, but as this paper that was published in 2021 looked at radiographs afterwards and actually found that sometimes they can actually decrease foraminal height despite, in theory, increasing the foraminal space. In recent years, endoscopic foraminotomies have become more popular due to the low morbidity of the surgery, small EBL, and outpatient characteristics of it. This paper early paper from Hofstadter's group looked at indirect decompression is effective for foraminal stenosis due to disc height loss versus maybe you should think of a direct approach for overgrown facets that have bony compression that you would need to actually directly decompress that indirect decompression wouldn't help with. Another recent meta-analysis looking at decompression for central or lateral recess spinal stenosis showed that the endoscopic approach met or exceeded NCID for ODI and VAS scores for both leg and back pain. And although a common criticism that it takes a long time in this group, that they were able to do it in less than 60 minutes for 51 minutes for an interlaminar approach for lateral recess stenosis. Once again, indirect is based on the idea of restoring foraminal height to improve ligamentous buckling, restore the tension band, and to increase the interpedicular distance versus a direct decompression when there's actually a fixed structural compression, usually a bony spur or osteophyte pushing in onto the nerve root. You might be better served going directly and directly decompressing that foramen. I know this is quick, but is there anybody have any questions?
What do you think about the endoscopic thing?
I mean, I think I last year I did probably 20 endoscopic cases. I think it's definitely a treatment that's going to only become more and more popular as the technology improves. But right now, I think if I were to go and practice today, I think the length of time, at least in my hands, wouldn't justify me doing that. I'd probably prefer a MIS or tubular approach to it. But I do think that as technology improves, as the instrument and the image quality improves, I think it's probably going to kind of replace a lot of these open or MIS cases.
Yeah, I bet you're right. I bet you're right.
Yeah. I don't. Is anybody doing endoscopic at San Diego Spine? I haven't seen anybody on the board at least.
No. Nope.
Not yet.
Yes, Dr. Cholkim.
Yeah,
Chol does it, but he's
Flash Cash Kim.
Yeah, nobody's doing it. Who's recruiting normal compensation, as far as I know. Which tells you something, right? If it's not viable in a non-cash circumstance, I worry about its value proposition.
Yeah, Bob I think it has because of the equipment involved, it has a fair amount of additional costs associated with it without a different reimbursement.
Right.
Under insurance, right?
I will say that
Okay.
I said I will say from the post-operative management of these patients, a lot of times, I mean, the scar is less than a centimeter, and a lot of these times these patients feel like they leave immediately and have no post-operative pain. So it's nice from that standpoint. I just think it takes a long time to do these procedures.
Well, that's the problem. I
Right.
think one saving grace for them in terms of cost may be that if they can be done without an anesthesiologist, then there's probably cost savings. But if you factor in the length of the surgery and time value relative to outcomes, I'm not sure that you're gonna get to the point where people will find value in it. See,
Yeah, we'll see.
the dual port reportedly, is less capital intensive, and there's some folks doing that without the same cost in the equipment. You still have to have the whole tower and all the other garbage, but the expense of the systems that are out there to do this in a single port is at least taken off the table. So that may have more legs.
Well, thanks, Ryan. Appreciate it.
Yeah, thanks, Ryan.
Good job.
Nice job, Ryan.